I think the larger global disruptions are things that are occurring for a wide range of medical supplies, where I think SRH products in particular are at a higher risk is they, I mean, many commodities within SRH are not purchased using a global procurement architecture like what we see for HIV, AIDS, TB, and malaria or vaccines, um, and so on. And as a result, there isn't a clear global agency which is looking at supply chain risks at the global level in a systematic manner, identifying them proactively, exchanging stock, etc. We do see some of that happen for family planning and contraceptives, a subset of SRH commodities, where the Reproductive Health Supplies Coalition, UNFPA, others have put together groups. And these are not groups that are created only for COVID-19, but have existed before for coordination across manufacturers and purchasers. So they are helping a lot in managing and rebalancing supply and demand. But that doesn't exist for a subset of SRH products, such as medical abortion commodities, many other things. So that's one global risk, which is not having the right architecture to rebalance. Then I think we are, as we look at data, we feel there is still enough supply of contraceptives and also of other SRH products in the system today for public purchasers. But we don't know if this is a time lag effect. What I mean by that is it just that we had enough stock and buffer in the system because of which we are able to manage, but because incoming supplies have been disrupted, will we see the effects of this in the months to come? So at CGD, together with colleagues from IQVIA, MyShaMeds, other groups, we are creating a data-driven method to help identify where the risks are the most significant of a country-level shortage occurring for specific molecules and items, including SRH. So that will help us give some more time to think about what the mitigation measures are and where should we prioritize. Then I think, you asked about, what are some longer term fragilities in the supply chain. So I think we know that we've started investing in data systems for supply chain for SRH commodities only, relatively recently, at least at the global and national levels. And I think that's an area which could help us both proactively prevent some of this and also figure out new ways to mitigate them quickly. Then I think I want to highlight two additional things. One is that the private sector channel continues to be a very important point of access for lots of women and girls to access SRH. And when we think about needs for protective equipment and PPE, when governments are collating their orders and placing them in the supply side market for PPE, we know is very scarce at this point. I want to make sure we are including the needs for health workers who work in private clinics, pharmacies, drug shops, many other forms of private sector service delivery. And if we don't include them, our risk of shortage of PPE will then translate into a service disruption risk in the private sector. So just something to highlight. And also, can we organize how they purchase their PPE in a somewhat more aggregated, somewhat more pooled manner? Then I think Monique had started mentioning this, but needs for PPE, both for the public sector health professionals, but also in the private sector and community health workers, there would be ways to shorten those supply chains. So instead of largely focusing on purchasing using long supply chains where manufacturing occurs in Asia or another low-cost production base, can we start doing some more local and regional production? So I think GFF, IFC, other colleagues have already started exploring that. I think that is a very positive trend and can give us, not just for PPE, can also help us resolve shortages through regional manufacturing of other SRH items. The last thing I want to mention is there are many social enterprises who have gotten in the business of distributing essential medicines in the private channel. Some of them are focused on SRH, such as e-pharmacy models or some kind of e-commerce distribution models. In many countries, they are the ones who are becoming the mainstream source of providing continued SRH access. So it's a reminder for all of us in the global architecture that how can we create financing vehicles so that such social enterprises for distribution of health products can be a more integrated part of the health system. And COVID-19 has given us an opportunity to think about that in a somewhat broader way than we have in the past.